Hello everyone, I'm presenting to you To Infinity and Beyond the Dizzy. I'm your presenter, Jessica Miles. We'll begin with case history, so we'll call this patient Buzz Lightyear. He's a 44-year-old male. Barriers to care, he uses a cane for ambulation, and then listed below are his current active problems. So when I saw this patient, he presented with persistent symptoms of severe imbalance, vertigo, nausea and vomiting, headaches, and falls. The vertigo is present with position changes when lying down or rolling over to either side, and it lasts a few seconds to minutes. The imbalance is present with a feeling of numbness or weakness in the left leg, and then he also has a veering sensation to the left when walking, which was also observed as he walked into the clinic. The veteran feels, since he was evaluated in May of 2021, that his symptoms have worsened and he's had an increase of falls to once a week. The veteran was diagnosed with migraines recently, and these are occurring once a week. He has a history of traumatic brain injury sustained during his deployment to Afghanistan in 2004 or 2005. He's not sure of that time frame. And then the veteran at that time was blown off the back of a Humvee. In 2018, he had an acute onset of left-sided weakness and was evaluated for a stroke with negative results. However, he underwent emergency decompression surgery, of what I won't tell you. So looking at this audiogram, he has a mild, gently sloping to a moderate sensorineural hearing loss bilaterally. SRT is 30 bilaterally, and then WRS of the right ear is 88% at 75 dB mast, and WRS of the left ear is 92% at 75 dB mast. So I was not the provider to see him for his initial vestibular eval in May of 2021. So keep in mind, our clinic does things a little bit differently. So these initial vestibular exams are just specifically more so looking, does the patient have BPPV or not? Is there any clinical significance in the findings that we should proceed with other vestibular testing? So that's kind of what this is in terms of ruling things out, and obviously looking at this, there's a lot going on, so there probably was some additional testing that occurred. So head shake within normal limits, no nystagmus present or subjective vertigo reported. We'll take a look at the positional test. So it was observed by that person that he had a torsional right downbeating nystagmus. And then this downbeating nystagmus is present in all of the positional tests, and it's pretty significant, as well as that right nystagmus too. But very much so, the downbeating nystagmus has significant beats and very high slow phase velocity. And then moving on to Dix-Hallpike's, both right and left, we see the torsional right and downbeating nystagmus is present. So immediately we're thinking, okay, this patient has to have bilateral anterior BPPV. And I was taking a look at the notes of that provider, and the veteran had stated that the left side was worse. So that's the side in the care of plan of care that we were going to begin treatment with. But however, this patient was lost to COVID and follow-up care from that, so it just became a whole mess. So he never received any treatment for this, which was very interesting, because then he came back, and that's when I saw him. So head shake was still within normal limits. Positional testing, we're still seeing the downbeating persistent in positional, and the Dix-Hallpike's. What's changed a little bit though is the positional testing is showing that he has a left and down in some instances, as well as the right and down. And then Dix-Hallpike's I found to be negative for BPPV. He has only the vertical downbeating nystagmus, still very significant in terms of beats and slow phase velocity, but there is no torsional component present. So a little different. So I just wanted to compare what we know. So here's the two evaluations. We know that head shake is within normal limits. Positionals, we're seeing that downbeat in all of the positional testing that we do. The initial eval on 521, we only saw right and down or just downbeating. And then the 1021 eval, we saw some instances of left and downbeating, and then right and downbeating. As for the Hallpike's, initial eval 521, right and downbeating with torsional component. So at that time, like I said, that provider was thinking a bilateral anterior BPPV. And then 1021, all we saw was downbeating nystagmus and no torsional component. So the thing to take away from this is downbeating nystagmus. It's persistent in all positional and positioning tests. Okay. So there's a clue there for you, as well as, like I said in that beginning portion, I withheld that information from you. What sort of decompression surgery did he have? So we'll see what you guys come up with. Also make sure to take a look at that case history again. So first of all, what would be your next steps in plan of care? I'm going to let you know I did see him for follow-up care, but I'm curious to see what your first step would have been in comparison to maybe what my first step was. And then second, are you thinking that this is more so peripheral, central, or non-localizing? Now I know you don't have all the information yet, but just kind of start thinking, and hopefully this will help you too as you're taking a look at that case history, what was presented in both of those initial results there. And then what's your diagnosis? You know, it's kind of hard to maybe say at this point. If you can come up with a couple, go through some differential diagnosis there. If you think you really know what the answer is to it based off of just this information alone, that's great. The answer is there with just this information alone, but for those of you that might need a little bit more in the videos to come, at least come up with a few different diagnoses that you think it might be. So thanks for watching my video, and good luck.